So this is the anconeal process of the anconeus that you need to know for coming up. And this is the medial coronoid process. Okay, this should have a nice, smooth, concave appearance, the anconeus. The medial coronoid process should be a nice, well-defined ski tip. Okay. So what do we see with fragmented medial coronoid disease? First off, the cranial caudal view sucks when you're looking at these. It's not very helpful. Okay, so I'm just going to tell you that. Okay, so what happens with dogs when they get fragmented medial coronoid processes? And again, it's not fractured, it's fragmented. And same thing that we've been talking about. It's young, large breed growing dogs. This is really, really common in all large breed dogs, and super common. It's probably the most common developmental orthopedic thing you're going to see in veterinary medicine. Okay, so what do they cut? They're lame in their front legs. Really, what happens? So they come in, and what are you going to see? Basically, what happens with fragmented medial coronoid disease? And again, most people really think this is a form of osteochondrosis. So that little tip, that little ski tip of the medial coronoid process is soft and breaks off. Okay, just like osteochondrosis. And as it breaks off, this little cartilaginous portion here can mineralize, form a joint mouse. Well, now, because we don't have this little tip of the medial coronoid process that normally should be there, now this joint is unstable. Okay, it's abnormal and it's not as stable as it should be. So the body recognizes it as an unstable joint. And again, what does the body tend to do with anything unstable like that as to try to heal itself? Well, body, again, just like back from the beginning, bone has very limited ways to respond to energy and to injury. And one of the ways that it can respond is let's put new bone around it. So it says this is an unstable joint. One way to stabilize the joint is let's put bone around the joint to try to stabilize it. That's the body's thought to try to heal itself. Okay, so as that happens, you get bone up in here near the radial head. So you get an osteophyte, a little spiculated area of bone near the radial head. You also get bone production all around this trochlear notch of the ulna. And remember, it's 3D, so it comes all the way around it, and it also comes on top of this, on top of the anconeus. So all of this bony production all the way around the joint, okay? And you'll start to see osteophytes, or little areas of bony production on the anconeus, taking away its normal concave appearance. Okay, sometimes you'll actually see a mineralized fragment of bone here. Most of the time it's cartilaginous and you don't see it. But what you do see is the lack of visualization of the ski tip. So the medial coronoid process, you can follow it up here, it comes up here, and then it gets very flattened and blunted and ill-defined and irregular in shape. You don't see the ski tip. Okay, that's how you recognize a fragmented medial coronoid process. Again, the cranial caudal view is nowhere near as helpful as the lateral view when you're looking for this problem. So what do we see here? Here's a lateral view. This one, they kind of flex a little bit and allows you to see this area better. But if I look here, so here's our ulna, here's our line. It comes up in here. I can still see it pretty well, but then I don't. Okay, it kind of looks like to me, it kind of comes like this. Okay, but I don't see a tip. I maybe can see a little fragment of bone right in here, but I don't see that well-defined tip of the medial coronoid process. It looks like it's coming like right in through here. So it's flattened and blunted and ill-defined. So now it's not fractured, it's not fractured off, it's fragmented. Okay, so now I have an unstable elbow joint. And due to the unstable elbow joint, the body says, well, let's put bone around it to try to stabilize it. So now I get osteophytes that start to form up here on the radial head. Look at this anconeal process. I get all this new bone formation on the anconeal process. These are osteophytes around the anconeal process. This part of the trochlear notch of the ulna becomes sclerotic. Okay, it's more white or opaque than it should be. And that's because there's bone being deposited all around here. And you see it kind of end on. Okay, and also we get osteophytes up here. I said that squared off portion of the humerus is called the medial epicondyle of the distal humerus. Well, look here, it becomes irregular in shape. I got osteophytes here too. I got osteophytes right in here. So the body says, this is an unstable elbow joint now. I'm going to put bone all the way around anywhere I can. Okay, and it's all due to this ill-defined, fragmented medial coronoid process. Okay, Here's a same thing on a craniocaudal view. So now we've got this area of bone formation in the region of the medial cornoid process. Again, I don't like craniocaudal views to look for this condition. Okay, here's another example. So here's another elbow joint. Here's the medial cornoid process coming up here, and I get to there and I really lose it. Okay, so I don't see a nice well-defined ski tip. It's coming probably somewhere in here. It's blunted. See the little bone opacity here. Osteophytes here, osteophytes here, osteophytes there, kind of the same thing. Normal here, I can see it here pretty well. Coming up here, right there. Over here, it's rounded in appearance. Okay, and now I start to get osteophytes here, and I start to get a little irregularity even up in here. Okay, so that's a fragmented medial cornoid process. So do me a favor, know the anatomy of where the medial cornoid process is on the ulna. Know what to look for. What you look for is what you don't see. You don't see a well-defined ski tip, and then you start to get osteoarthritis or osteophytes forming around the elbow joint. Okay, so that's a fragment, and don't call it a fractured medial cornoid process. Okay, a lot of vets do, and that's wrong. Okay, the next condition that we're going to talk about is it sounds similar, but it's totally different. It's an ununited anchineal process. So again, this isn't a fractured anchineal process. It's not a fragmented anchineal process. It's called ununited for a reason, which we're going to talk about right now. Same signalment, large breed, fast growing dogs, less than a year of age. Okay, they come in, they're lame. Okay, so again, you're going to radiograph their elbow joint. So remember, let's go back to this picture here. So if you look here, again, this is the anchineal process right in here, right? So that's the anconeus. This whole little thing here is the anconeus, okay? Well, in dogs, especially large breed dogs, when they're really, really young, this part of the ulna, and they have another growth plate in here, typically comes from a separate center of ossification. This part of the anchineal process right in here. But as they start to become skeletally mature, like in when they're 2-3 months of age, this should fuse with the rest of the ulna, this little humpy thing right in here. Okay. If it doesn't fuse, then it stays a separate piece of bone. Okay. So if it doesn't fuse and stays a separate piece of bone, that is an ununited anchineal process. So it's not that it fragments away, you can still see it. Okay. It's not that it's fractured. It didn't unite with the rest of the ulna normally. So it is called an ununited anchineal process. And guess what you're going to see? You're going to see here's our anchineal process. It looks like a lucent fracture line, but we know it didn't fracture. It just never did fuse with the rest of the ulna. Okay, so this one's an easy condition to see. All you do, a lot of times you can flex the elbow a little bit. It'll help you see this area better. And you look for a lucent line and a chunk of bone up in here. That is what is remaining of the anchineal process. Okay, so here's a real life x-ray of a dog that has that. So it looks like there's a fracture line, but we know it's not fractured. It's just, this is the anchineal process that never did fuse with the rest of the ulna. Okay, and because of that, guess what happens? Now it's an unstable joint, and the body says, let's put bone around the elbow. So then you start to get osteophytes, same thing all the way around the elbow. Not uncommonly, you will see dogs that have two conditions on the same elbow. They may have an ununited anchineal process, and they also might have a fragmented medial cornoid process. Okay, so what do you do about these two conditions? Well, if the dogs have an ununited anchineal process, depending on how big a piece of bone that is, sometimes the surgeons can go through and debride that area right in there and put a screw across there to make it stable. Okay, with a fragmented medial cornoid process, they can go in again with an arthroscope and clean that area about, remove all the mineralized debris, and curettage that area of soft bone. Okay, in my experience, even though you spend a lot of money, or you don't, but the owners do spend a lot of money fixing this or fixing that condition, you give it a year or two, and the dog's still going to have really bad arthritis of the elbow. The surgeons probably don't want to admit that, but that's really the truth. Okay, so here's another dog. He's got both. So if I come up here, here's his medial cornoid process. It looks like it's flattened. I really don't see it very well. So I think he's got an FCP, but I also know he's got an ununited anchineal process, because here is the anchineal process. There's a line between them. It never did unite with the rest of the ulna. leading to an unstable elbow joint. And over time, that's going to put a lot of arthritis and bone around that joint. Okay. Okay, the next one we're going to talk about condition is another developmental condition. Usually happens again in large young breed dogs, same thing. But a lot of times these dogs that have this condition will not be lame at all. Okay. The good thing about this, as opposed to all of the other conditions that we just talked about, a retained cartilaginous core is self-limiting and typically goes away on its own. And a lot of times they are not even lame to begin with. But you'll see it from time to time. You need to know what it is so you can recognize it. And retained cartilaginous core, for the most part, only happens in one spot. It will only happen in the distal aspect of the ulna. Okay, this is the growth plate of the ulna. That's normal, but a retained cartilaginous core is exactly what it says. It will has usually a triangular kind of ill-defined area that extends into the metaphyseal portion of the bone in the distal ulna that's full of cartilage. It's retained cartilage from the growth plate. Okay, and you'll see this on radiograph. See this like witch's hat in the distal end, distal metaphyseal region of the ulna. And you can see it here. There's a little witch's hat coming right in here. That's a retained cartilaginous core. Typically, in my experience, these dogs are not lame at all, and you don't do a damn thing about it. You leave it alone, and it'll go away as the dog gets older. The next one we're going to talk about is another developmental orthopedic disease that, guess what? It also happens only for the most part in dogs that are young and large breed dogs. Okay. This one can happen in any dog of any age, but probably 90% of the time, maybe 95% of the time, it will happen in only dogs that are less than a couple of years of age. Okay. And this is called panosteitis. Panosteitis is relatively common. And it's super, super common in German Shepherds for whatever reason, and causes significant lameness, significant pain. Okay. It's also one of the weird diseases in veterinary medicine that, as far as I know, has no human equivalent. It's a specific thing that happens only in dogs, doesn't even happen in cats. I don't think it happens anything like it really in human medicine. Okay, so what middle-aged, large, young, large breed dogs. So this is the nice thing about panosteitis. It is a self-limiting disease. Okay, number one, nobody knows what causes it. Okay, and number two, there's nothing you can do to really treat it other than control pain. Okay, and the good news is you give it a little bit of time and it goes away, and the dog will be perfectly normal. Okay, so that's a good disease to get. Okay, so it can happen in one or more legs. It usually happens in the mid diaphyseal regions of long bones, so radius, ulna, humerus, tibia, and femur is typically where it's going to happen. And most of the time, it'll happen in more than one leg. So people will describe this animal as coming in with a shifting leg lameness because he's got lesions in several limbs. And you wake up today and now my left radius is hurting more. So today I'm going to limp on the left side. But then you wake up a couple days later and now it's your right rear leg that's hurting more than the rest of them. So now you're limping on the right rear leg because today that's hurting more than the other ones. So people will describe pano as a shifting leg like lameness. Okay, so what do you see with panosteitis? Typically, you're going to look at the marrow cavity of long bones. And sometimes some of these lesions, especially early on, is very subtle. Okay, so you have to look really closely, but I'll give you a clue on how to do that. So if you look at this at first glance, you're going to see that little drawing there. I don't really see anything wrong, but if you look closer in the marrow cavity, there's some little vague areas of very faint increased opacity kind of down here too, in the mid diaphyseal portion of that part of the bone. And that's what you see with panosteitis is you see increased opacity in the mid diaphyseal portions of long bones in the marrow cavity. Usually you don't see anything along the cortex, although sometimes if it gets really bad and severe, you'll see a little periosteoreaction around that part of the bone. Okay. Early or later on, more severe, then you see this opacity inside the marrow cavity becomes really, really opaque and very obvious. And now I see little mineralized areas of periosteoreaction around that part of the bone. Most of the time you don't get periosteoreaction, but you do see these areas of increased intramedullary opacity. Doesn't happen in the metaphyseal region, only in the diaphyseal region. Okay, so real radiographs. So here's a front leg of a dog. Here's the humerus, and I can see this vague area of increased opacity in the marrow cavity right here. There's probably a little vague area also right here. Okay, and definitely see this larger area of increased opacity in the diaphyseal portion of the left ulna. Maybe a little bit right in here. I don't know. Okay, here's the rear leg. So here is a vague area of increased opacity in that part of the femur. Okay, that is a typical lesion, a typical panosteitis lesion that you're going to see. Okay, so here's another one. So if I look here, this is that ulna. Look at that ulna, that area of vague increased intramedullary opacity. So early on, what I typically look for is I look, it's pretty easy to spot really this area of increased opacity. And if you're not sure, you always shoot the radiograph in the same position of the opposite limb and see if the other limb looks the same or different. Okay. And so the other thing that I look for when I'm looking for panosteitis, remember before we talked about here's the cortical bone over here. Okay. And it's got an outside periosteal surface, but it's got an endosteal surface. That's the inner margin of the cortical bone that you can see right where it's next to the medullary cavity. Well, in a normal dog, the cortical bone, like down in here, it looks very well defined, and the endosteal surface is well defined. It passes the Sharpie test. You can pick it out real easily. Okay, except where you have pano. Where you have pano, now I have increased opacity in the medullary cavity, which silhouettes, remember that word, with the cortex, and I lose that well-defined endosteal surface, okay, because of the panosteitis lesion. Okay, here's some other examples. So probably vague pano down in here, okay, definite pano right in here, increased intramedullary opacity. Notice how the endosteal surface here and on the cranial cortex is well defined until you get up in here, and then it's not as well defined. Okay, so again, panosteitis on the other femur as well, and here it is in the radius. So again, a lot of times it'll happen in multiple bones. So that's panosteitis. You look for areas of vague, increased intramedullary opacity, and usually in the diaphyseal portion of long bones. It can happen in multiple bones. And what do you do about it? You tell the owner, this is a good thing for him to happen. He's going to be really, and they can be super painful. He's going to be painful for a while. You can control the pain. You can put the fentanyl patch on the dog to control the pain. You can put them on non-steroidal anti-inflammatory therapy. None of that's going to accelerate healing. You just got to give it time, and over time, it'll completely go away. The dog will be non-clinical. They'll be normal, happy, healthy dogs. And if you re-radiograph that area, it'll look completely normal. So it's a self-limiting disease. Really not much you can do about it. Okay, the next condition we're going to talk about is another one called hypertrophic osteodystrophy, and is abbreviated. The acronym is HOD for dystrophy, hypertrophic osteodystrophy. Okay, so what do you see with hypertrophic osteodystrophy? Let's go ahead and look at the pictures here. You'll see lucent lines in the metaphyseal region of long bones. Again, this is typical in large breed, fast-growing dogs. Okay. And again, Great Danes, German Shepherds, Basset Hounds, for whatever reason, in my mind, come to mind of what you see this. This is usually in pretty young dogs, so 5-6 months of age. And these dogs come in that have hypertrophic osteodystrophy, and these dogs are unbelievably painful, super, super lame, okay, to where the point where they may not even walk, okay. They can, but it's so painful they don't want to, and they're very reluctant to walk. And when they do, they may start walking and start screaming as they walk. Okay. So what is hypertrophic osteodystrophy? Typically what you're going to look for the cause of it, nobody knows. Okay. It's just one of those weird things. Nobody knows what causes it. And again, the good news is it's like pano. It's a self-limiting disease. You get them through the pain and it'll go away on its own, no matter what you do. That's the best kind of disease to get. Okay. So what do you look for radiographically? Well, here's like a distal radius and ulna, right? And there's the growth plate of the radius. There's the growth plate of the ulna. So here's the growth plate of the radius. Normally the growth plates are well defined, thin, and the margins of the bone next to them are very well defined. Okay. But with HOD, hypertrophic osteodystrophy, you get a lucent, vague area in the metaphyseal region of the bone that is adjacent to the growth plate that roughly parallels the growth plate. Okay, you can see it here in the distal radius. That's the HOD lesion, this vague area of lucency here. In the lateral view here, here it is in the ulna, kind of vague area of lucency that kind of parallels, but is in the metaphyseal region of the bone. Okay. And then some of these dogs, pretty commonly in this case, you'll get little ill-defined periosteal reactions around those lesions. Okay. So typically it's going to happen in the distal radius and ulna, as well as the distal tibia and fibula. Okay, so let's look at an example of that. So here is a dog early on with hypertrophic osteodystrophy. So here is the epiphyseal portion of the radius. This is the epiphyseal portion of the ulna. This is the growth plate. Note that the growth plate is really well defined. Okay, same thing with the ulna. Here's in lateral view. Well, the lesion you're looking for with hypertrophic osteodystrophy is this. Okay, this is this vague area of lucency in the metaphyseal region that parallels the growth plate, but is not the growth plate. Okay, here's the same thing up in here in the ulna. That is a hypertrophic osteodystrophy lesion. So a lucent area, not well defined, that roughly parallels the growth plate, but that's in the metaphyseal region of the bone. Okay, here it is on the other leg. So this is the hypertrophic osteodystrophy lesion here and here and a little bit up there in the ulna. Okay, here it is on another dog. So here again, that's the growth plate. See, the growth plate is, and the ulna is conical and it's well defined. Here's the growth plate of the radius, but this little area of lucency right here and the area of lucency right above it and here is the hypertrophic osteodystrophy lesion. And this dog's getting these periosteal reactions around it. He also has hypertrophic osteodystrophy here in the proximal aspect of the radius. So there's the growth plate. That's not the lesion. This is the lesion underneath it in the metaphyseal region with periosteal reactions around it. Okay. Again, the nice thing about hypertrophic, this is a severe case. Look at these ill-defined periosteal reactions around there. Okay. The good thing, like I said about this case, this condition, hypertrophic osteodystrophy, is it is another one of these self-limiting diseases. The dogs are extremely painful. It can get very obvious radiographic abnormalities like this dog has. But if you give it time, you control the pain, it will go away. And if you would re-radiograph this dog's tibia and radius and ulna and do it, re-radiograph it 2 or 3 months later, it's going to be completely normal in appearance. It completely remodels, goes back to normal. Okay. Again, nobody knows what causes this. Back in the day, they thought it might be viral. Okay. But they never could prove it. Back in the day, they thought it was a vitamin C deficiency like rickets in people, but that would be really unusual because dogs don't require vitamin C to begin with. So it's hard to be deficient in vitamin C when they don't require it to begin with. So that didn't work out. Bottom line is nobody knows what causes it. But the good news, it's self-limiting, although it's extremely painful, but it will go away given time. Okay, hypertrophic osteodystrophy. So here it is very early on, here it is kind of medium on, and here it is as it's trying to heal, and now you get all these periosteal reactions. Again, given time, it's going to go away. Okay, the next developmental orthopedic disease we have to talk about, and you may have heard about this, is avascular necrosis of the femoral head, otherwise known as Legg-Calvé-Perthes disease, which I would imagine is named after 3 physicians that, again, the MDs have to name things after themselves to satisfy their egos. Okay, so Legg-Calvé-Perthes disease, what is that? This is one of the few developmental orthopedic diseases in dogs that happens only in very small breed dogs, like toy breed dogs. Almost all the other ones are large breed, fast growing dogs. Okay. This one's a skeletally immature Yorkie or little teacup poodle or things like that. And it always presents exactly the same way. They're usually 4 to 11 months of age, really small breed dogs, and they come in and they have unilateral rear limb lameness and a lot of soft tissue atrophy from disuse atrophy of one of the rear limbs. It's almost always, in fact, I don't think I've ever seen it being bilateral. It's almost always just unilateral. Okay, so they come in, they're really, really lame. Okay, they don't want to use like 3-legged lame. They don't want to use that leg at all, and lots of atrophy. So what causes this is that in a normal animal, you get blood supply to the epiphyseal portion of the femur, the head of the femur, that comes from these retinacular arteries. So they come across this part of the bone, across the femoral neck from the femoral artery, and it supplies blood to this portion of the bone. Okay, that's in an adult dog. It also gets a little bit of blood from the ligament of the head of the femur, or the ligamentum teres, and a little vessel that comes through that area. So that part of the femoral head has to have blood supply to stay alive. Okay. Well, in young dogs, most of the femoral head gets its blood supply from the synovial fluid. Okay. In really young, small breed puppies. Not much blood supply comes from here, and these vessels here really hasn't formed yet. Okay. And so if you have some kind of trauma, the dog tweaks his rear leg in some way, it will prevent these vessels from ever forming, which means we have decreased blood supply to the femoral head, which then that part of the femoral head dies. And once it dies, it starts to resorb. Okay. So what do we see in dogs radiographically that have Legg-Calvé disease? Is we look for this area right in here. This is a normal femoral head and neck right in here. This is abnormal. This part of the femoral head is lucent because it's dead and it's resorbing bone back out of it. Okay. So you look for unilateral, ill-defined lucencies in the epiphyseal portion of the femoral head on one side. And look at the amount of atrophy. These bunch of thigh muscle over here, a bunch of thigh muscle over here. It's really decreased over here compared to that side. So lots of atrophy, unilateral, lucent lesions of the femoral head. And because you're resorbing your femoral head, this whole part of it in here is being resorbed. Now the coxofemoral joint space itself appears widened compared to this side because I'm resorbing my femoral head. So now the joint space appears widened. Okay, that's Legg-Calvé. So the key to Legg-Calvé, teacup dogs, little bitty dogs, young dogs, 4 to 6, 8 months of age. Look for lucency in the femoral head itself and a lot of soft tissue atrophy, always unilateral. Okay, if you don't do anything about this, they're going to get super bad degenerative joint disease and arthritis of that joint. Okay, typically what the surgeons will do at this point is they go in and they do a femoral head and neck ostectomy. Okay, you could do a total hip replacement, but dogs do super well, especially the smaller the breed, the better, with a femoral head and neck ostectomy or an FHO. And so for an FHO, and a lot of vets mess this up if you try to do them. So you want to make sure do the FHO properly. So an FHO, you don't just remove it here through the growth plate and take this part out. Okay, in FHO, you always want to go from the neck of the right in here, the neck of the femur, and you make a line from here and a cut all the way down here to the lesser trochanter. You take out this entire part of the femoral head and neck. You don't just cut it here, you cut from here to here, and you'll learn that in surgery. If you leave this part in, the dog's still going to remain painful and get a lot of arthritis. So you have to take from here to here all this out. And after that, the dog, a little bit of rehab, they'll gain their muscle mass back and they'll run around like nothing ever happened for the most part. Yes, sir.
Do you put like a synthetic head on it, or the bone regrows, or what?
No, it doesn't. It forms like a fibrous union. That's kind of a faux fake femoral head. It will never really grow completely. If you radiograph it afterwards, you'll never see bone there, but it just fills in with basically fibrous tissue, and the dogs seem to do well. Okay, this is Legg-Calvé, again, is only a dog thing that I've seen, but very commonly in young kittens that fall off the tree or roof or whatever, they won't have Legg-Calvé, they just fracture their femoral neck. Okay, and same thing, you'll go in there and take that out, do an FHO on those cats. And it happened to one of my cats one time, and you give them 3 months afterwards and they're running around like nothing ever happened. Climbing trees, running around like nothing happened, but they don't have a femoral head on one side. Okay, so that's now if it's a large breed dog, but this doesn't happen in large breed dog. If it was a large breed dog that had trauma, then a total hip replacement, which we'll talk about later on in this lecture, is a possibility. Okay, but on the other hand, and here I'm going to say some stuff that I get on my soapbox that you will learn if you don't know already. Everything in life comes down to money. Okay, and so if you talk to a surgeon that actually does these procedures, they're going to tell you, yeah, you should probably think about doing a total hip, put in a titanium hip, replacing the hip, and you're going to spend $8,000 to do it. Okay, and that's all well and good. Okay. But the smaller the dog is and a cat, and especially if they're not big and fat, and the other hip looks okay, a femoral head and neck ostectomy works fantastic, and it will cost maybe $1,000 to have done. So and the outcome is going to be the same. The dog's going to run around like normal. Okay. Which one do you want to do? Well, it's up to you. You can spend $8,000 and have a dog that's happy and healthy, or you can spend $1,000 and have a dog that's happy and healthy. Okay. So what is the surgeon probably going to tell you to do? What's the best thing to do? Put a total hip in. Why? Because they get to make the money on it. Okay. Unfortunately, that's the way it works, but that's the reality of it. Okay. Okay, close-up view. So look at this remodeling of the femoral head. We got all this lucency in the femoral head up in here. So again, easiest way to be done with it, take it out, make a cut between here, take all this stuff out. It's called an FHO. You'll learn about it and when you talk about orthopedics and surgery. Very commonly performed procedure. Okay, and again, FHOs work best the smaller the dog is, or in cats. Okay, if it's a great big 100-pound Labrador, it's not the best thing to do. Okay, a total hip in that case would be better. Although if you can't afford a total hip, then you can still do an FHO on those dogs. They're probably not going to be fully functional, but if you want a dog that's a racing dog or a hunting dog, it probably is not a good option. But if you want a dog that hang out in the backyard and sit on your couch, it'll work fine. Okay, so here again, unilateral. This side looks very normal. This side is a chronic FHO dog, really wide joint space. This femoral head is completely remodeled. And again, you can go in all these osteophytes here, but you could go in and just remove this part and the dog's going to be probably just fine. Okay, so we've talked about developmental orthopedic disease. Now we're going to talk a little bit about, move on to acquired orthopedic disease. So dogs that are mature and what can happen to those dogs. Okay, the first one we're going to talk about is a disease condition that sounds a lot like hypertrophic osteodystrophy, HOD, except this one's totally different and doesn't happen in young dogs. This happens in old dogs. And this one's called hypertrophic osteopathy. Okay, so one of them is abbreviated HO, the other one is abbreviated HOD. Okay, HOD is the one we already talked about, super painful, the loosened areas that parallel the growth plates in the metaphyseal region of young dogs. Okay, hypertrophic osteopathy, completely different disease in older dogs. So what happens in these dogs? This is a really cool disease condition that does also happen in people pretty commonly. So these are usually middle-aged to older dogs, and most of the time they have concurrent disease in their lungs. Usually it's a mass lesion in the lung, so a tumor. So they might have a really bad, really large mass lesion in their lung, and a bronchogenic carcinoma. Sometimes it can be a benign condition, but it's a big mass, like a big old granuloma that can be on the lung. And sometimes it can be due to other things in the lung that act like mass lesions. So you can see this sometimes in dogs that have severe heartworm disease. Okay, dogs with heartworm disease, they have great big dilated tortuous pulmonary arteries that in reality, the body is kind of dumb and it thinks, well, these are big mass lesions in the middle of the lung. So it kind of acts like mass lesions and can also cause hypertrophic osteopathy. So any breed, any sex, usually middle-aged to older dogs. Okay. So what do we see with this? Let's just go look at some. So what do you see with this is you see what people will describe as palisading periosteal reactions in the long bones. And typically it starts down here in the metacarpals and the metatarsals. So you see all of this bony production along the entire diaphyseal portion of the metatarsals and metacarpals. Typically that's where it starts, and then it moves up proximally. Then it'll involve the radius and the ulna or the tibia and fibula. You see absolutely no bony lysis. The cortical bone is still intact, still well-defined, but you get all of this periosteal reaction that starts to form. You can see it here. This periosteal reaction that starts to form along the diaphyseal portion of the metatarsals and the metatarsals. You can see it here. You can see it here, and it can become really obvious and really apparent. If I blow it up, you can see it kind of has a spiculated appearance, but the cortex is still well defined. It looks very nice. There's no lysis. Okay, and here's another example. This one's a lot more severe. So you get this palisading periosteal reaction that starts in the metatarsals and then will spread proximally up the limb. Okay, And this is, again, hypertrophic osteopathy, totally different than hypertrophic osteodystrophy. Okay. What causes this? Well, it's one of those things that nobody really knows for sure, but there's theories on what happens is usually you get a mass lesion in the lung. And we know that one of the nerves that passes through the caudal portion of the lung area in the mediastinal space is the vagus nerve. Well, people have thought that maybe you get this mass lesion and it irritates or sits next to or puts pressure on the vagus nerve. And the vagus nerve supplies a lot of branches that go caudally and to the limbs. And it stimulates that irritation of the vagus nerve can stimulate a periosteal reaction to form of these long bones, the metatarsals, metacarpals, tibia, fibula, radius, ulna. Okay. So nobody knows that for sure. But we do know that almost all the time when you see this, these dogs will come in. Some of them aren't lame at all, but some of them will have thick areas of their limbs because they get edema because the lymphatics can't drain very well. But most of them really aren't that lame. But if the bottom line, what's going to happen here is you're going to be out and your owners are going to present some dog to you. It's a middle-aged to older dog, and they come in and they're going, I don't know why his limbs are all swollen up. And you go, oh, I don't know either. Maybe he's got a cellulitis. Well, no, more than one limb. Well, okay, then cellulitis probably a little less likely. Okay, so you radiograph him and you'll see this. You'll see these palisading periosteal reactions, and that should ring a bell in your mind. And you can say, huh, this might be this hypertrophic osteopathy stuff. We need to shoot some chest films. Okay, and you're going to shoot chest films, and sure enough, there's going to be a big mass in one of the lung lobes. Okay. And then you'll know, well, this is hypertrophic osteopathy. The cool thing is if you go in and you remove the mass lesion in the lung over time, this will also go away. Okay. So it's kind of a weird condition. And it doesn't probably 90% of the time, this will be due to some type of mass effect in the lungs. But it has also been reported with mass lesions of the uterus and of the prostate. Okay, so it doesn't always have to be in the lungs. It can also happen with a mass in the uterus or the prostate. I don't know why, but that's just life. Okay, so hypertrophic osteopathy. So again, here's these ill-defined, palisading periosteal reactions, no bony lysis underneath it, it'll be multiple limbs. Usually if you radiograph the right side and the left side, they're very symmetrical. They look exactly the same. And the thing is, it's got a lot of edema, a lot of swelling around the limbs, may not be very painful at all, but you need to go take chest films. And if you don't see any in the chest, then take abdominal films or ultrasound the abdomen because you got to find the mass. It's going to be in there somewhere. Okay, kind of a cool disease. And again, this dog had metastatic lung disease. So there's a nodule here, there's a nodule here, no great big mass lesions, but probably one of these is probably sitting right next to where the vagus nerve lies and maybe irritating it or something like that. And again, nobody really knows for sure that's the cause of it, but there's some theories that talk about that. Okay, what time is it? I think this is a good place to stop for the weekend. Y'all have a great weekend. Don't do anything that I wouldn't do. So you're totally open there. So, have a good weekend. Maybe look at a little bit of radiology in your spare time because your next exam is coming up quicker than you think.
Thank you.
Have a good weekend. I will see you guys on Monday at 9.
Bye.
All right. Bye.